Abducen, the sixth cranial nerve nucleus, is situated at the middle level of the pons. Nucleus is situated ventral to the floor of the fourth ventricle, where it is closely related to the horizontal gaze center. The fasciculus of the seventh nerve curves around the abducent nucleus and produces an elevation in the floor of the fourth ventricle known as facial colliculus. Lesion at this area will lead to ipsilateral sixth nerve palsy and ipsilateral lower motor neuron seventh nerve palsy. Central connections are the same as main third nerve nuclear complex. It can be divided into fasciculus, basilar part, intracavernous and intraorbital parts. Fasciculus passes ventrally to leave the brain stem at the pontomedullary junction, just lateral to the pyramidal prominence. In a deep groove between the lower border of pons anteriorly and the pyramid of the medulla posteriorly. Lesions here are as follows. As it passes through the PPRF, lesion here causes foval syndrome, where patient will have ipsilateral 5th, 6th, 7th and 8th cranial nerves palsies and central sympathetic fibers are involved. As it passes through the pyramidal tract, lesion here causes Millard-Gubler syndrome, where patient manifest with ipsilateral 6th nerve palsy along with contralateral hemiplegia. Next is the basilar part. It leaves the brain stem at the pontomedullary junction and passes upwards close to the base of the skull, where it is crossed by the anterior inferior cerebellar artery, which is the first branch of basilar artery. Then pierces the dura below the posterior clinoids and crosses the apex of petrous deep to the petrosphenoidal ligament and enters the cavernous sinus. Sinus. Petrosphenoidal ligament is stretched between the posterior clinoid process and apex of temporal bone. The trigeminal nerve passes above it, while Abducen's nerve passes below it. Causes of lesion in this part are usually acoustic neuroma, nasopharyngeal tumors, raised intracranial pressure, basal skull fracture. Grade-Nago syndrome. It is most frequently caused by mastoiditis or acute petrositis. Intracavernous part of abducent runs forwards inferolateral to the internal carotid artery, lower level than the third and fourth nerve. Lesion here will cause sixth nerve palsy and postganglionic Horner syndrome known as Parkinson's sign. Intraorbital part passes through superior orbital fissure within the annulus of Zint between the two heads of the lateral rectus muscle, and supplies the lateral rectus muscle through its bulbar surface. Few important features of the sixth abducent nerve are: it has the longest intracranial course of any of the motor nerves of the eye. It makes a sharp turn over the petrous ridge, which makes it vulnerable to trauma and increased intracranial pressure. Destroying a nucleus impairs not only abduction of the lateral rectus muscle on the same side but also impairs adduction of the medial rectus muscle on the opposite side, because each nucleus contains neurons whose axons cross the midline and ascend in the medial longitudinal fasciculus to the medial rectus muscle motor cells in the oculomotor nuclear complex. Whereas destruction of an abducen's nerve root impairs only the lateral rectus muscle on the same side. An isolated sixth nerve palsy is therefore never nuclear in origin, that is very close to the nuclei.